Mm. Hello, everyone. My name is Shannon, and today I'll be demonstrating how to properly do a head-to-toe physical assessment on a patient. Today we have Ms. Robinson here. First thing we want to do is start off by verifying her name and date of birth to make sure you have the right patient in front of you. So, would you repeat your full name and date of birth for me, Ms. Robinson?
Cassandra Robinson, date of birth 5/4/1955.
Excellent. And what day is it today?
Today is Thursday,
Okay. And what year are we in?
2018.
Okay. And who's the president?
Donald Trump.
Yes, ma'am. All day. Okay, good. So you want to ask those questions to test a person's LOC or level of consciousness to make sure they're completely aware of place, time, and who they are, circumstances surrounding them being here, etc. Now I want to start off and test the cranial nerve. So I'm going to get you to make some facial expressions. Take a big smile for me. Puff your cheeks out. And tongue out, side to side. Excellent. Okay, and close your eyes tight, and then I want you to open them wide like you're surprised. Excellent. Good. So this tests all the different muscles in the face and stuff, and I want you to close your eyes for me and tell me what size you hear my finger snap on.
Right, left, right, and left.
Okay, and that tests their auditory senses. All right, now I want you to look straight ahead at my pen and follow with just your eyes for me. Excellent. Now focus on the wall far out there for me. And then when I tell you to look at my pen again.
Oh, I'm sorry.
All right. Now look at the pen. Excellent. This tests the person's convergence in the pupil size changes from looking at somewhere far away to focusing on something close up. Okay, good. Now just give me your hands and squeeze them tight for me. And push down on them. Okay, now turn your palms up and push up against mine. Excellent. All right, and could you uncross your legs for me? And relax your feet. And I want you to press your foot down like you're hitting the gas pedal. All right, and pull back the other way. Good. And try to raise your leg against my hand and pull down against it. Same on the left leg. Here, up and pull down. Okay, relax your foot and hit the gas and pull back. Good. So that's plantar flexion and dorsiflexion, and just testing her her motor responses and making sure she can resist gravity and apply force, normal power as needed. While you're doing that, you can also be looking at your patient's skin, making sure that there's no breaks, no significant scars to note, and also you can be asking them if they had any history of surgeries that left any scars, or if they have any open wounds or bruises and so forth on their skin. But looks like Ms. Robinson is everything is pretty warm, dry, and intact, so there don't seem to be any skin issues. So now we'll move on to a respiratory assessment. First, again, you can visually inspect the chest area and make sure there's no barrel-chestedness or no hunchback or anything going on in the respiratory area. And now what we want to do is listen in all the fields of the lungs. I'm going to start at the back. Let's get you to lean forward, and we want to listen in a Z-like pattern from side to side. And you should take a few deep breaths for me. Excellent. Another. Okay. And a couple more. And now I'm going to test the front vesicular sounds. All right, thank you. All right, so your lungs sound clear. No diminishment, no coarseness, no crackles, rails, or anything. Sounds good. Pretty sure you've never been a smoker, which is a good thing. So aside from that, for a respiratory assessment, why are you going to, you want to try to kind of count the patient's breaths per minute without letting them know, so that they don't kind of make any adjustments for the number of breaths they're taking in that period. Typically, normal range is 12 to 20 breaths, and the average person usually is around 14, 16 on any given day, from what I notice at work. And Ms. Robinson seems to be right around there as well. Doesn't have to be perfect. You just want to make sure there's no labored breathing or nothing's changed. The thing about an initial physical assessment also is it's a good place to gauge the person's baseline and see where their respiratory function is. You see what their skin is like. You take note of how they move, and these are all the things you want to notice if anything were to acutely change and the patient's conditions start to decline. This way you will have a better judgment of what they should be, and if any changes occur for the worse, you can note them quickly. Okay, now I'm going to take a listen to your heart, Mr. Robinson. Yeah, just relax. And so when listening to the heart, I want to make sure I listen to the pulmonary valves as well as the aortic valves, and take note of how they open and close. Take note if there's any swishing sounds, which could indicate arrhythmias or murmurs such as AFib. And I'm also watching the carotids here as I take her pulse and apical pulse. Okay, so everything sounds good there. Heart sounds are S1, S2, which are the loved up sound. You hear all healthcare workers often talk about how the heart should sound. They don't seem to be any adventitious sounds as well, so seems to be in good cardiac condition. She doesn't express any history of cardiac problems other than a little hypertension. So we can move on to the gastrointestinal area. First, you want to take note of that as well, and just kind of visually expect patient's stomach seems to be flat and non-distended. And we want to listen for bowel sounds as well in 4 different regions of the abdominal cavity. And you pretty much just listen for the gurgles as if the stomach was growling, to make sure there's no gastroparesis and that food and everything is flowing properly the way it should. Okay, so she has active bowel sounds in all 4 quadrants. You need to slightly palpate to try to feel for tenderness if there are any areas that feel uncomfortable for the patient, or if there are any bulges or anything that could indicate a possible hernia, which everything seems to be good here. Thank you, Mr. Robinson.
You're welcome.
Now, for a genital urinary assessment, it typically doesn't have to be invasive if the patient doesn't have any ailments or anything afflicted in that area. So most times you can ask the patient, do you have any problems voiding or having a bowel movement?
No.
Or any burning during urination?
No.
Or any problems with continence?
No.
No, I've never used a catheter.
No.
Let's see. So if any of these were issues, then it would be a time that we'd have to maybe inspect and make sure the area is cleaned properly. Make sure the foliar is inserted right, and maybe even do some teaching or confirmation to make sure the patient knows how to insert a foliar and remove it. But since that's no issue with Ms. Robinson, we can continue to move on. Start with next we'll do the musculoskeletal system. Let's get you to stand for me and look at your range of motion. Okay, let's stick your arms out for me in front of you. All right, by your side here, above your head. All right, good. You put them down. And just lift one leg, down, lift the other. Okay, and now kind of kick out in front of you with each one too. Excellent. So it looks like all fields of range of motion and bilateral extremities, upper and lower, are functioning. Her sensation is intact. Don't seem to be any mobility issues with Ms. Robinson at all. She doesn't use any canes, walkers, or assistive devices to move or ambulate with. So patient is in overall good health. And this concludes how to properly do a complete head-to-toe physical assessment in a timely fashion on a patient. Something that you should practice doing every day on your patient, and take note of any changes that may have occurred from the previous assessment and from shift to shift. All right, appreciate you guys for watching. Thanks.